Okay, so we are going to talk about liver transplant indications, workup and bridge to transplant. And if you look at pediatric liver transplant, it's way below what adult transplant is getting done. Most of the hospitals would be doing 1 or 2 pediatric transplants a month, whereas most of the adults you would be having around 20 to 25 transplants a month, the same hospital. So even in India, 10% of all the liver transplants that are taking place are in the pediatric age group. So it's not as big as the adult pool, and I think one of the reasons is we don't have alcoholic liver disease. I remember the time when I was doing my MBBS and I was in the liver unit doing my MBBS and internship, and my rounds in the morning would start with ascitic tap of all the alcoholic liver diseases. And it used to be 8-9 patients, you're just putting in the ascitic tap. You start with the first, by the time you finish the last, you're again refilling the bottle of the first one. So alcoholic liver disease is a major contributing factor, and the other thing is NASH in adults, which are causes of liver transplant. In children, we don't see that. Now, again, you have 2 types of liver transplants. You have a living donor liver transplant where a relative will give a liver. So you will have a blood relation that will be giving the liver. Either it will be one of the parent or chacha or mama or somebody who's in the blood relation. Then you have the disease donor where you get a, not exactly a cadaveric liver, but you get a liver of a patient who's brain dead. So if you look at Japan basically prefers living donor. It's because of their religious beliefs that they don't go for dead donor transplant. Asia and Middle East, we prefer living donor because the cadaveric pool or the disease donor is very little. So we always have a waiting list for the pediatric age group. And depending on the waiting list, whether it's a super urgent list or an urgent list, these patients would be categorized to get a diseased liver. So mostly we'll end up doing a living donor. Whereas in the North America and Europe, they usually do a diseased donor transplant. So for them, the indications of doing transplant are much easier because you're not having a donor who's going to be giving a part of the liver. So we always, when I talk to people in Birmingham, like Wadia has a tie-up with Birmingham. So when I talk to them, for them, it's like here if we say parents are not affording and they don't want to do a transplant, in the UK it would be a crime. And in the UK, those patients would be taken away and the government and their whatever the structure is would insist that the patient undergoes a transplant. He would be put into hospice care. So it's a different scenario there. Now, what decides on the number of liver transplants that are being done? One is what's the prevalence of the liver disease in that particular region and what's the access to care. So if you look at liver transplant, it's very diverse. I mean, some centers would say we will do it free of cost, they will arrange for donors and everything to come. Some centers would be charging you somewhere around 20 to 30 lakhs per transplant. So it depends on the accessibility of care as well as the demand of the prevalence that is there. Second is the lot of times, and it's very realistic view, lot of times though parents want to do a transplant, but they have certain other needs. They would say that we have other children to look after and we don't really want to go into the transplant here. And so you will see one scenario where the parents would refuse a transplant saying we've got other children to look at. And there will be another scenario. I have a patient. The older girl underwent a transplant. She's now around 13 years old. She had another child and that child turned out to be biliary atresia. So in those days we were not doing the genetic testing. Now I got the genetic testing done of the child who had biliary atresia and that turned out to be PFIC actually. So a lot of times your biliary atresia are actually more of genetic disorders. But because we don't have that time frame, they'll end up getting a Kasai syndrome. So now the mother had already donated for the first child. Now when this second child needed, she had a failed Kasai. When the second child needed a transplant, She was very keen on getting it done because she had excellent results with the first child. She made sure the grandfather gave the liver. And that child is also doing extremely well. So to get somebody in the same family undergoing liver transplant and some two family members giving is a rare scenario. Most of the times you'll get somebody, you're working up one parent. It's usually a parent who ends up giving. You're working up one parent. If they turn out to be unfit, you work up the second parent. Hardly you'll get other relatives actually donating. So that is the problem that occurs in living donor. Deceased donor, as I told you, if it's a super urgent, your liver will go to those patients first rather than for pediatric. And the cost is the other issue that people think of. It's not only the cost of the transplant at that time, but the cost is also of giving the immunosuppression lifelong. That immunosuppression, monitoring of immunosuppression in the current scenario would cost something like 4,000 to 5,000 per month. So even if you're counseling for transplant and you may arrange for various charities to give and make it free of cost for the patients at that time, but you also have to consider that they have to take these medicines lifelong and whether they'll be able to afford it. Now, what are the common indications for liver transplant? If you look at worldwide scenario, you have cholestatic disorders, so you have biliary atresia, PFIC. Then you have metabolic disorders, which is Wilson's, tyrosinemia, organic acidemia, urea cycle defects. ALF is one of the major cause of liver transplant. Then you have any chronic liver disease due to any cause, and now the child is decompensating. And then you have liver tumors like hepatoblastoma and HCC. So these are the common causes. You will definitely have other causes which are there. If you look at our center, what were the indications for liver transplant at our center? If you see, majority were biliary atresia, almost 30% were biliary atresia and a failed Kasai. Second is PFIC. And PFIC, if you look at the data, it's basically PFIC 2 that requires a liver transplant earlier. PFIC 1 actually you try and avoid because they have extra hepatic manifestations. Then you have Wilson's disease. Now if you look at that age group, I have not put the age group, but it's there in the next slide. So chronic liver, where you have cryptogenic, you don't know the cause, you worked up everything, you've done genetic, autoimmune, Wilson's, everything, nothing's coming. Those are the other causes. Rarely you'll have allergy, Carolese, mitochondrial hepatopathy. Now, mitochondrial hepatopathy actually may be an indication for transplant, but if they have extra hepatic manifestations, like suppose they have a kidney involvement or they have a neurological involvement, you would not be putting them to transplant. So we've had scenarios where we've diagnosed mitochondrial hepatopathy. You know the child needs a transplant, but we've actually told the parents, don't go ahead, because neurologically the child will not be able to do it well. But GRE usually they would require transplant because of hepatopulmonary syndrome. Because with venoplasty and stenting, they do very well. But ultimately they develop hepatopulmonary syndrome. And that would be one of the indication of doing a liver transplant. Hepatoblastomas, veno-occlusive disease. We've had patients with familial hypercholesterolemia who are not controlled with medical line of management. And then they've been referred to us for transplant. Most of the times we've not done a transplant for them. We've just changed their medications and they're okay. And you have all the other genetic causes now because we are sending a whole exome. We pick up a n number of genetic causes and those become indications for transplant. So if you look at the age group when LT comes, if you have failed biliary atresia, by the time you are actually planning an LT is around 6 to 8 months of age. Most of the times you don't land up doing LT so early. One is because of the weight of the child. The weight of the child at this age would be around 5, 7. It becomes difficult to do a transplant. So most of the time you build them up nutritionally. You tell them, let the weight increase. We want an optimum weight of 10 kilo, but if not, at least 8 kilo, 7 kilo before the child is taken up for surgery. So you will have very early indications with biliary atresia. Most of the Wilsons will come to you by around 7 years. And they usually come to you as ALF. So they'll come to you, they've never been diagnosed, and they suddenly come to you as ALF with a very high INR. You need to put them on SLED, you need to put them on plasma exchange, and then they require a transplant. PFIC 2 usually comes around 2 or 3 years of age. They have and their reason for transplant would be intractable pruritus. their pruritus is so bad that they'll end up getting a transplant. And as I told you, Budd Chiari, usually they come with hepatopermeate syndrome, and that you would see around the first decade, not that early. Now, if you look at ALF, what would be the need for transplant in ALF? As we know, fulminant hepatitis A. Right now, we have 2 patients in the ICU, and both have presented as ALF, but one turned out to be because of leptospira, and the second, we don't know the cause because he's non-A, non-E. But that patient is on SLED and PLEX. But otherwise, your indications would be hepatitis A if they are fulminant, drug-induced. A lot of these patients actually, because of jaundice, they'll end up taking some Ayurvedic drugs. And I'm sure Beenal will remember this patient with arsenic poisoning, where we had a patient who came with ALF, had taken some Ayurvedic drugs, and it turned out to be arsenic. And we couldn't do a transplant in that patient because arsenic is deposited in the bone marrow. And if you transplant, the new liver will also get the arsenic from the bone marrow. So we lost this child actually. But these are the other causes. Parvovirus, dengue, adenovirus is one thing that you have to keep in mind, especially if you have non-A, non-E hepatitis, then adenovirus could be cause, and sometimes you have unknown causes of ALF. Transplant in ALF is actually very, very urgent. You may need to transplant within 4 to 5 days because that child doesn't give you a window to operate. If you lose that window, the child is going to go into sepsis, and then you lost that chance. So that chance of doing a transplant is very less in that ALF. So that was about ALF, but in a chronic liver disease, when do you decide a child needs transplant? You have certain scoring systems that help you to make a decision. So in children more than 12 years, you look at the MELD score. In children less than 12 years, you look at the PELD score. Then in case of Wilson's, you look at the Wilson's disease index. So these are various scoring systems that tell you what is the mortality if the transplant is not done. Nobody will tell you, okay, this is the score, you need a transplant. No one will tell you that. People will tell you what is the mortality if transplant is not done, or what is the mortality if within the next 1 year with this particular scoring. So this is the MELD score, and you have bilirubin, INR, creatinine, and in case sometimes you take the serum sodium also. And then you look at the MELD score, anything more than 17, you are ready for transplant coming up. You used to use the Child-Pugh classification, so you had your A, B, C classification. And again, we talk about mortality. If a patient comes in whichever class. The problem with this is what I pointed out, that you have an INR of 6. INR of 6. So you have an INR of 6 and a bilirubin of 14. You would be in this particular group that will come to your 3 points and 3 points, so 6 points. So 6 points would be somewhere around Child-Pugh B if you don't take the other things into. And somebody who has an INR of 2.3 and a bilirubin of 4 would also be getting 3 points and would land up in the same classification. So one would, with this INR of 6 and bilirubin of 14, this patient is a candidate for transplant. But the same child with INR of 2.3 and bilirubin of 4 is not a candidate for transplant. So Child-Pugh score doesn't help you that way. Then for ALF, you have the King's College criteria, especially for paracetamol and non-paracetamol poisoning. And non-paracetamol poisoning, it's very simple. If you have an INR anytime more than 6.5, make sure that INR after giving vitamin K, not before giving vitamin K. After giving vitamin K is 6.5 with hepatic NCAF, or you have any of these 3, then you are listing the patient for transplant. It's not a foolproof scoring system, but it helps you to make a decision. And never are you going to make a transplant decision based on 1 point scoring system. You're going to follow up these kids, maybe day 1, maybe day 2, maybe day 3, and see the trend. And if the trend remains the same or it worsens, then it's transplant. If it improves, then you still have some time. Now we come to workup. So what is important is identifying when not to do a transplant. That's the first thing I would tell you. Identifying when to do a transplant is easy, but identifying when not to do a transplant is very, very essential. I still get so many patients in my clinic who come because from other centers they've been recommended transplant. And they'll end up coming for a second opinion. And you realize this patient doesn't require transplant right away. Okay, so there's a lot of pressure of transplant to occur right away. I mean, moment a child is diagnosed as PFIC, the first thing that will be offered is transplant. But you know, there's still time. We could still wait it out. You don't need a transplant immediately. So to identify when not to do a transplant is very, very essential. Because you're going to put a relative to give a liver, you're going to make the parents spend that much amount of money, and it's a high-risk surgical procedure. So you have to be very sure when not to do a transplant. Once you've decided that this is when a patient requires a transplant, you talk to the parents, you talk to the family, not even only to the parents. Talk to them when the patient requires a transplant. What's going to be the outcome? What's going to be the survival rate? 1 year, 5 years, you give them that data. Try and first get the blood group cross-match done. So blood group of the child and the parents or whoever is going to be the donor has to be similar. Though nowadays you do ABO incompatibility blood group also. But preferably you want to have the same blood group of the donor and the recipient. So workup will be divided into two aspects. One is the recipient workup and second is the donor workup. So if we are looking at deceased donor, then what will be an ideal donor? Somebody you get a call in the middle of the night. So you have a ZCC, that is a zonal transplant committee. And some hospital registers that we have a potential donor. So what is a potential donor that you're looking at? Ideally you want somebody who's less than 40. Somebody in whom trauma is the cause of death. Brain death has been proven. Hemodynamically stable when the surgeons go to procure this thing. There is no fatty liver, no chronic liver disease, and no other transmissible disease like HIV, hepatitis B, C. So this is an ideal donor. You're not going to get this. Practically, you're not going to get this. So you have an extended criteria donor. So in extended criteria, you know there is a risk in taking that, but at least you're not putting somebody as a living donor for this patient. So there may be a little advanced stage. You may be taking somebody even up to 60, 65. There may be some amount of liver damage that is there, some amount of fatty liver. There may be a prolonged cold ischemia time because suppose the liver is coming from Aurangabad. So then you may be having that time where the liver is having a cold ischemia time. Patient may be on ionotropes at the time when you have retrieved the liver. So all these are high risk criteria, but you can take them. What happens is then that waiting list that you have gets shortened and you have a more donor pool. Otherwise you're too restricted with the number of donors that are potential donors. If you look at living donor, what would be the living donor criteria that you're looking at? You want somebody who's between 18 years and 50, 55 years. The 50 to 55 depends on the surgeon, what they prefer. You're going to take a detailed medical history examination. What is important is hypertension is one where you can take the patient. But a diabetic, you would want him not to be taken up for the donor transplant. I have a child who's Crigler-Najjar and they are very keen for transplant because Crigler-Najjar, they require phototherapy for hours together in a day. Mentally, he's a little subnormal. So I first told the parents, get a neurology to see him. If they feel that the child understands what he's going to go through, will understand as an adult that he has to take immunosuppression, then we go ahead with the transplant. So they went to a neurologist. The neurologist gave a go ahead, yes. He's low IQ, but he can still manage. Okay. Now the donor workup was done. Everybody in the family is a sickle cell trait. They got, I think they tested, they have a very big joint family, so they tested everybody possible, and everybody in the family has a sickle cell trait. So the first thing that comes to your mind, no, you cannot give. Then we took a hematologist opinion, and hematologist gave a go-ahead, yes, you can still go ahead and do a transplant. So there are a lot of criteria, you don't usually get an ideal donor, but you have to play around with it and take, okay, this is possible, we can do it. So other things that you would do is blood group, hemogram, LFT, RFT, blood sugar, thyroid functions, lipid profile. You would do a triple H, you will do EBV, CMV, VDR. Whether you want to do PCR, you want to do IgM, IgG, varies from center to center. Then you do an ultrasound, look at the fatty liver. If all that is fine, BMI of the donor is okay, then you plan a phase 2 where you're doing a CT scan or an MRI of the donor, basically to look at the anatomy, and anatomy to decide whether it's possible to, take a split liver and do the anastomosis. So this is your workup that you're going to do for the donor. After you've done this workup and you're sure that this donor can give the liver, then there are consults that you have to do. You need a pulmonology consult. That anesthesia will not be a problem. You need a cardiology consult. You may do an echo, stress test. You may do other more refined tests if required. You will, if it's a female donor, you'll need a gynec consult, a pelvis, a pap smear, a dental consult, anesthesia consult. Psychiatric clearance is very important. They should be psychologically stable, not to break down. Because liver transplant is not something that's done and next day the child is home. It's going to be a long-run process. And a nutrition clearance. Most of the adult patients would either be undernourished or they'll be obese. You will not get a BMI at the right value. So a lot of times we have to tell them, the donor, either lose weight or put on weight. So that again becomes a waiting time. So as I told you, acceptable donors are the ones who are 18 to 50 years, ABO compatible blood group, no comorbidity, or maybe one like hypertension. You look at an LAI. LAI is the liver attenuation index. That is basically you're looking at the fat in the liver. You don't want steatosis more than 20%. The BMI should be less than 25. Graft ratio is what to recipient, body weight ratio is what you're looking. It should be more than 0.8. Remnant volume should be more than 30% of the total liver and anatomically suitable for donation. So these are all the various criteria that you look when you're doing a donor workup. The donor also has to be told that most of the times he'll be in the hospital. After the operation, he will be on antibiotics for a day or two. And he will be extubated either in the operation theatre or he may go onto the ventilator post-op, but he may be in the ICU or the HDU for 24 to 48 hours, and he will come down from the HDU to the room in say 24 to 48 hours, and probably he'll be discharged by day 5 of post-operative day. Plus you have to follow them up to see how the liver is growing. And so this is what basically you will tell the donor. For the recipient, you have to first confirm the indication of transplant. It's very easy to say you need a transplant. Anyone with jaundice not coming under control, you say transplant karwa lo. It's not that easy. I would still say you need to know when not to do a transplant. You have to determine the severity of the disease. Consider alternative treatments to transplant. For example, tyrosinemia. Tyrosinemia, earlier we had no treatment, so everybody would undergo a transplant because they would either develop RTA or they would get hepatocellular carcinoma. So you don't want them to do that. Now you have NTBC available, so there's an alternative to transplant. So you could put them on NTBC lifelong and they do very well. In fact, we have the highest series of tyrosinemia, and now some of the kids have been on NTBC for almost 10 to 12 years and they are doing extremely well. So you have an alternative to transplant here. So you can offer them the alternative. Then contraindications to transplant. Like I told you, mitochondrial hepatopathy, if you have a multi-system involvement, you would tell them transplant is not possible. Then infections you have to see in the child. Like last time we did a transplant in a child with an ALF, and the child had parvovirus. We still went ahead with the transplant. The transplant was a success, but the child died of an aplastic anemia because the parvovirus went and affected the bone marrow. But at that time we didn't have a choice, because with ALF the child was sinking completely. So you have to weigh the pros and cons as to when to do it, when not to do it, what infections will you do. And then cardiac malformations you have to keep in mind, especially Alagille syndrome. So I remember one child was advised transplant at another center. They came to me, and Alagille syndrome, and we got a cardiac angio done, CT angio, and peripheral pulmonary vessels were all small. So transplant was out of the question. So you have to be very, very sure when you will be doing a transplant. Now once you planned a transplant, you have to rehabilitate the patient first, prepare the patient first. Make sure all the vaccines are up to date, including all the additional vaccines. You may give an accelerated vaccination program, because once you transplant, you won't be able to do that. Second is get the growth. The more the weight of the child, better at the transplant. If they are malnourished, transplant is a risk. The risk increases. Make sure the dental care is taken, because you're going to intubate, you don't want to have a tooth coming out during intubation. A lot of these patients are sarcopenic and osteopenic. Quite a few have fractures before transplant, so make sure that is taken care of. Make sure their social status, logistical issues you have taken care of. They should not run out of money, have a nervous breakdown because of that. And make sure parents understand what is transplant. If the child is old enough, he understands what is transplant. Motivate them. They need to carry on and prepare them to deal with all possible issues. Just one case scenario. We have a 2-year, 9-month-old boy. He was diagnosed with PFIC, 2 with portal hypertension, with decompensated chronic liver disease with coagulopathy. His PELD was 21.6 and his CTP was class B. His weight pre-transplant was 12.5. So with that PELD, you know that the mortality is going to be high and you have to do a transplant. Now pre-transplant, this child got admitted with sepsis and abdominal distension, melena. And he was treated with meropenem, vancomycin, fluconazole. Now the window that we got to do a transplant, because he had started decompensating, he has already gone into sepsis, and to do this transplant. So as soon as the sepsis got controlled, we took him up for transplant. He underwent a living donor transplant, the father gave. Because he had that bad sepsis pre-transplant, he had a pneumonia post-transplant. He needed prolonged ventilation. And then now the child currently is 2.5 years, post-transplant, attending school, adequate weight gain with minimal immunosuppression. So conclusion, LT can be life-saving and life-changing. However, correct indication and right timing is essential. Pre-transplant preparation of donor and recipient, you need to prepare them properly so that you get better results. And when not to do a LT is something that everybody should know. So thank you very much.